Good afternoon, fellow Auburn students and Auburn faculty. This is Don Fuller. Today we're here doing suture demonstration video. Today we're going to work on doing 5 interrupted sutures on our pad provided by Auburn University. Today we're going to be using a 5/0 Ethelon, just the size and the suture. There are several different sizes of suture you can use and several different areas you can use them in. This being an Ethelon, which is a nylon, you can use a nylon or a proline anywhere. You can use a chromic gut anywhere in the oral mucosa or the fingernails or the fingernail beds. You want to use a Vicryl Rapid anywhere on the face, ears, nose. You also can use a regular Vicryl and a monocryl on lacerations that are deep and wide lacerations like the one here. The thing to remember about sutures is taking your time, getting them right, tying your knots, making sure the wound is well approximated yet not too tight. Also making sure that your knots are on the same side of the laceration. And in consideration for taking those lacerations out and the areas of the body, on the face you probably want to use a 6/0. And that anywhere between 3 to 5 days those sutures would come out. On the arms and arms, upper extremities, you use a 4/0 or a 5/0. For flexion, those sutures will stay in a flexion area. Those sutures would stay in 7 to 10 days. On an extension area, they might stay in 10 to 12. For the hands, you want to be sure you're using a 5/0. And those need to stay in for 7 to 10 days. Your low extremities, which is your legs, knees, you can use a 4/0. Those need to go the same as the arms for extension and flexion. Flexion 7 to 10 days, and an extension area 10 to 12. And on the feet, you need to use a 4/0, and those need to stay in anywhere from 10 to 12 days. So you'll need to be sure that you educate your patients, depending on what type of suture you use, of when they should come out and how to maintain those sutures. So today what we're going to talk about is we're going to do a demonstration. We're also going to talk through the appropriate way to use anesthesia, how to prep a wound, how to actually insert interrupted sutures, and aftercare. So the things that you're going to need to know as far as local anesthesia goes, lidocaine is used most of the time on most of the areas. 1% for the face, nose, ears, those areas that are very scalp, that are very vascular. You want to be sure to use a lidocaine with 1% with epi. The epi constricts the blood vessels in that area and decreases the amount of blood bleeding that you'll have in that area. So be sure we get together all that information. First and foremost thing you need to do though is you need to be sure you wash your hands. Go into the room, introduce yourself to the patient as to who you are. You want to inspect the laceration, obtain as much history as you can about the laceration, how it happened, if there might be any foreign bodies or contamination in the wound, and also ask if their tetanus is up to date. If they haven't had a tetanus shot within the last 5 years, then it's indicated for them to get an update on their tetanus. So you need to be sure to give that. So we'll move right into what we're going to do as far as prepping the wound, laying the sutures, aftercare, and cleaning up. So to start with, what you want to do is make sure you have your lidocaine. Usually you can use a 10cc syringe if it's not a large laceration, 25 gauge needle. You want to be sure to use either chlorhexidine or betadine. And what you'll do, just as a demonstration, you'll start at the center of the laceration and you will work around, making a big circle away from the center of the laceration. Prior to injecting your local. When you do that, you don't want to go back across the laceration itself after you've moved away from that area, because it can drag contaminants back into the laceration and cause an infection. So you'll take and you will inject your local into the area of surrounding the laceration on both sides. It will be uncomfortable for the patient. Be sure that you're verbalizing to them that it will be like a bee sting. But once it gets numb, the only thing they should feel is pressure. Then you're going to take off your gloves, throw them away. Go ahead, clean your hands again if they are soiled. Make sure you have your kit open. Open it sterilely. Don your sterile gloves, and you're ready to prep the laceration. You're going to prep the laceration in the same fashion, either with betadine or chlorhexidine in a sterile manner. You'll start at the inside of the center of the laceration, working your way around the outside and away from it, never returning to the center again, not to drag contamination back into that laceration. You also want to be sure that you inspect the laceration well. You can use your forceps, look in, make sure that you don't have any debris, that you don't have any foreign bodies that need to be removed prior to your laceration repair. If you do have any foreign bodies or debris that need to be removed, remove those foreign bodies if you can. And then be sure you copiously irrigate the laceration with a solution of normal saline or either a 1 to 10 ratio of betadine and normal saline. Usually a 60 cc syringe works very well for those irrigations. And just be sure that you're talking your patient through what is going on and what you're doing during this procedure. So you want to be sure you clean, make sure you've irrigated, and then you're getting ready to lay your first suture. So if you haven't already, you'll take your suture. If you don't ever have it on the field, make sure somebody opens it and just drops it on the sterile field. Don't let them touch the sterile field. Then you have to start all over. So most of our kits are going to contain some common instruments that you're going to need. One being a needle driver, 2, a pair of scissors, and 3, a pair of pickups or forceps, whichever you prefer to call them. Your forceps are very important because you're going to use them to pick the needle up when it is not on the driver so you don't stick yourself, and make sure that you're safe with your sharps. So we're going to remove the suture from the packaging. We're going to take our forceps, hold on to it, and we're going to make sure that our needle driver is secure, needle is secured to our needle driver at the base of the needle where the suture meets the needle. We're going to explain to our patient what's going on. We're actually going to assess real quick before we start. Give them some little pushes and pokes with your forceps. Ask them if they feel any pain. Be sure that they know that they should not feel any pain, but they may feel some pressure. If everything is good with your anesthesia, you're going to let them know you're going to do your first suture. You're going to make sure that your sutures are evenly placed, that your wound is well approximated, and that they are tight but not too tight, because you don't want the skin overlapping itself. You want to have that skin pull together very well so it can heal. So we're going to use our needle driver with our needle. We're going to do our first stitch in the center. We're going to start on one side of the laceration, go through the skin, through the middle of the laceration to the opposite side, pushing the needle through the opposite side of the laceration. We'll grab the needle, sharp end of the needle with the needle driver, pull it through. At this point in time, you can drop your needle on the sterile field away from you. You should have enough suture that you don't have to worry about getting stuck with it. You'll take your needle driver for an interrupted suture. You're going to wrap your needle driver twice with the suture, grab the end tail, and pull it through. You do one in the opposite direction, wrap your needle driver one time, grab the tail, and pull it through. You're going to make sure that all your knots are to one side of the laceration, and then trim the edges. We're going to use our forceps and pick up our needle. Grab it with a needle driver and lock it in. And we're going to go about halfway in between again, between the original first suture and the end of the laceration. So 90-degree angle will go in through the laceration, come out on the other side. Unlock your needle drivers, pull your suture through, leaving about an inch tail, dropping your suture needle on the field, wrapping the needle driver twice, pulling the tail through, and in the opposite direction, and pulling it through, creating your knot, making sure that they are on the same side of the laceration. We're going to do this 3 more times, demonstrate 5. Be sure to instruct your patient too while you're doing this, if they can, be real still, not to move or disturb the sterile field you have created with the drapes that are included in your kit. So the third suture, we're going to go in, one side of the laceration, through, and out to the other side. Unlocking your your needle drivers, pulling them through, dropping your needle on the sterile field, wrapping the suture twice around the needle driver and pulling the tail through. And in the opposite direction. And cutting your excess. And I had learned that suturing just takes practice. Again, you'll pick your needle up with your tissue forceps, attached to your needle driver. Go in through one side of the laceration, well approximating it to the other side. Unlock your needle drivers and pull your suture through the lac, leaving a tail, dropping your needle on the sterile field, wrapping it twice, pulling the suture through. In the opposite direction, one loop and through. This is suture number 5. Gonna go in, 90-degree angle, through, well approximating it to the other side, pulling your needle through, dropping it on the sterile field. You're going to do 2 loops on your needle driver, grabbing the tail, pulling the suture through. 1 in the opposite direction, grabbing the tail and pulling it through, making sure your knots are all on the same side, and trimming the excess. So we've demonstrated 5 interrupted sutures. Looking at the wound, is well approximated, not too tight. The skin is not overlapping itself under the sutures. The knots are pulled to one side of the laceration. You're going to make sure that you secure all of your sharps once you're done with your lac repair. Put them in a sharps container. You want to clean this area very well. You want to apply some neomycin or bacitracin or triple antibiotic ointment to the area and put a dressing on it. There are some major aspects that you need to talk with your patients about after a lac repair. The first one being that they need to leave this dressing in place for the first 24 hours. Doesn't need to be disturbed. That's a very important time for the wound to start healing. Also need to talk with them about how to care for it after that first 24 hours. They're more than welcome to remove the bandage after the first 24 hours. They can wash it with some warm soapy water. They don't need to scrub it vigorously. Just very gently with a washcloth. Pat it dry. Put some Neosporin on it or some bacitracin triple antibiotic and cover it again. It's important for these patients to also know that if they see any signs or symptoms of infection, redness, swelling, drainage around the laceration, if they start running a fever or have any adverse reactions to the suture itself, that they need to report to the emergency room or report that to their primary care physician or urgent care, wherever is most appropriate for them at the time. Patients also need to be aware that they do need to come back and remove those sutures in a timely manner whenever they are instructed to. They also need to follow up with their primary care provider if they have any further issues after the sutures have been removed. Patients also need to be aware that if they have had contact with any contamination or foreign body, that they may go home on some antibiotics, depending on the patient themselves and where the laceration is. We did talk a little bit about different types of sutures. We're just going to go over those again. Again, this is just a simple interrupted suture. It's 1 suture at a time with 2 trips around your needle driver tight, 1 in the opposite direction tight, and cut your ties. A mattress, horizontal mattress suture can be used for areas that are high tensile, like the knee or anywhere that might have a lot of tension on them. If you have very deep ones, you can use vertical mattress sutures, which are a little bit different. But you're learning your basic suturing technique is imperative to moving on to the other techniques. You need to be sure that patients take their medications if you do prescribe them medications as directed, and they need to finish the entire course of antibiotics if you've given them antibiotics. And again, if they have any adverse reactions, they need to be sure that they return to the emergency room, primary physician, or they need to follow up with an urgent care. So thank you today for observing my suture demonstration. I hope you enjoyed it, and I look forward to seeing other suture demonstrations in the future.